Hello everyone. Let us continue with the topic pharmacodynamics. So in the earlier lectures we have seen how exactly the drugs interact with their receptor, what are the types of receptor, what are the different transducer mechanisms by which the drug action is converted into drug effects. Okay. So let us come to the next concept, that is combined effect of the drugs. Okay. Now it is seen that nowadays seldom the physicians prescribe only a single drug. Okay. Or there are so many formulations which are available in the market which comprise of combination of drugs, that is it may contain more than one active ingredient in them. So a lot of combinations of the drugs are available. Even the several dosage regimens, they hardly contain one particular type of drug. Mostly it happens that a particular patient has to consume more than one tablets at a time. Okay, so in such cases wherein two or more drugs are given simultaneously at a time, or maybe in quick succession, that is you have to consume one tablet after the another. So in this particular situations there are a few consequences which can be seen when such type of combination of the drugs is done. Okay, so there are three possibilities which may happen when you combine the drugs, okay, at a time. So first thing is, either both the drugs may be indifferent to each other, okay, or whatever drugs you are consuming at a time, so they may be indifferent to each other, so it makes no difference if you combine them. Or they may exhibit synergism, that is when two are combined together, enhanced action may be seen. Okay, or one drug may enhance the action of other. Or another possibility is antagonism, that is one drug may suppress or inhibit or reduce the effect of another drug, or it may totally abolish the action of another drug. So these are the three possibilities which may take place when you combine the drug. Now such kind of combined effects or alteration of the effects of one drug by another drug, that is known as drug interaction. So in some way or the other, if one drug affect the another one, or both the drug affect each other, so that time it is known as a drug interaction. Now sometimes it may be a favorable one, or sometimes it may be an unwanted one. Sometimes it may abolish the action of another drug, so it may not be advisable. Okay, or both the drug may affect each other. Okay, so that may not be advisable. So such type of interactions or drug interactions may take place at two particular levels, that is either at pharmacokinetic level or at pharmacodynamic level. Okay, so pharmacokinetics we have already covered in detail. So over there under ADME there were various situations in which we have seen that the two drugs may interact, right, at the absorption step. If the two drugs are utilizing the same transporter, obviously there is a competition, one may inhibit another one, as we have seen. Also in the metabolism also we have seen, then one drug may inhibit the metabolism of another, or one drug may enhance the metabolism of another drug. Okay, even in case of excretion also we have seen that one particular drug may enhance or inhibit the excretion of other drug. So these are known as the pharmacokinetic interaction. Now the same way pharmacodynamic interactions also may take place. Okay, so we have seen what pharmacodynamics is, how exactly the drug interacts with the receptor, or how it causes the changes in the biological effect. Okay, so two drugs when they are given together, there may be changes in the actions or the effects of one drug which can be made by another drug. So those type of interactions are known as pharmacodynamic interactions. Okay, now coming to the combined effects. Now how exactly at the dynamic level, how it can happen, how one drug can alter the action of another drug. Okay, now as we have seen earlier, there are three possibilities when more than one drugs are given in combination. Either they will not make any difference, or synergism will take place, or antagonism may take place. Okay, so let us consider the synergism. So this term, it is actually a Greek word which is derived from these two, that is, syn means together and ergon means to work. Okay, so they work together to enhance the actual action. Okay, so it will produce more action as compared to the individual actions of the two drugs, or individual effects of the two drugs. Okay, so when the action of one drug is facilitated or increased by the another, that time they are said to be synergistic in nature. So what happens exactly over here is enhancement in the activity of maybe one drug by another drug. Okay, so now in this synergistic pair, you can call it as a synergistic pair, the two drugs which show synergism, both the drugs can have action in the same direction. Okay, so when the two drugs produces same type of action, so when you combine them, so what will happen? Synergistic action will be produced. Or given alone, one may be inactive, but it may still enhance the action of other drug when both the drugs are given together. Okay, so there are two possibilities in case of synergism. Either both of them can produce the same type of effect, so when you combine them, there will be additive action. Or there may be such pair in which one of drug does not have that particular therapeutic effect. Only one of them has. But that second drug, which actually does not have any therapeutic property, it actually does not show that type of action, but still it will enhance the action of another drug. Okay, so that is known as the potentiation. So accordingly, there are two types of synergisms which can take place. Okay, so the first one is the additive. Okay, additive action. So here what happens is exactly the type of pair over here. Both of them show the actions in the same direction. The effects of these two drugs are in the same direction. The same type of action is shown by the two drugs. So when you combine them, the two effects of those two drugs will simply add up. So if you can see that effect of the combination of these two drugs, say for example, if you consider two drugs A and B, so the effect of the combination of the two drugs A plus B is equal to the effect of drug A plus effect of drug B. So simply the effect because of the two drugs, they simply add, and the consequence is the addition of the two effects of the two drugs. Say for example, aspirin and paracetamol. Both of them have analgesic property, both of them have antipyretic property. Okay, that is, they can abolish the pain and they can reduce the fever. So when you combine these two drugs together, aspirin and paracetamol, okay, aspirin also has analgesic property, paracetamol also has analgesic property. So when you combine them, exactly both the actions, both the analgesic properties of both the drugs will simply add. Next, you can consider the next example, that is nitrous oxide plus halothane. Both of these are general anesthetic, so they can be combined together. So both the actions of nitrous oxide and halothane, they will add up. Similarly, amlodipine and atenolol, both of them are antihypertensive, they can reduce the blood pressure. Okay, so similarly, if you give these two drugs in combination, obviously more decrease in the reduction in the BP will take place. Simply the action will add up. Similarly, ephedrine and theophylline, both of them are bronchodilator in nature. Okay, so both the drugs in this particular pair, they have the same type of therapeutic property. If you can see, both of them have the same therapeutic effects. So when you give them in combination, both the effects due to both the drugs will simply add. Okay, now one more concern when you give certain drugs in combination is the side effects. Okay, now since all the effects will simply add, okay, so obviously that particular drug will show the adverse effects also, right? or the unwanted effects or the side effects. One particular drug may not have only one property, they will have multiple properties, right? So what about the side effects then? Will they not add up? Yes, of course they can add up, provided they show same type of side effects. But mostly two drugs do not produce the same type of side effects. Okay, so supposing if aspirin produces certain side effects and paracetamol it produces some other side effects, so obviously their action will add up, their therapeutic property, that is analgesic property, will add up. But since they have different types of side effects, they will not add up over here. Okay, because they are totally different from each other. Okay, so it is always better to combine these two types of drugs. Okay, rather than if you try to enhance the action by increasing the amount of aspirin, so obviously what will happen to the side effects? The side effects shown by that only one drug, that will also be increased, right? So it is rather better to enhance the activity by combining the two drugs. The therapeutic property will add up, but side effects of this drug will be lower obviously, and this also it will be lower. On the contrary, if you only increase the dose of the aspirin, obviously their side effects also will increase, right? So it's always better to combine the two drugs rather than increasing or rather than using higher doses of one particular drug of the synergistic pair. Okay. Then the next type of synergism which can take place is the supraadditive or the potentiation. So here the effect of the combination is greater than the individual effects of the components of that particular pair. Okay, say for example, the effects of combination of drug A plus B, it is greater than the sum of the effects of the two drugs, that is effect of drug A plus effect of drug B. It is not the same. In the earlier case, additive, what we have seen, that only simply they add up. But here what is happening? The action, when these two are combined together, their effects, it is greater than the simply addition of the effects of the two drugs. Okay. So in this case, mostly in this particular situation, one of the component is inactive as such. That does not have that particular therapeutic property. Okay, like say for example acetylcholine. Okay, acetylcholine, it is actually a neurotransmitter at the parasympathetic division, right? So it actually may alter several physiological functions, right? Okay, but physostigmine, that does not have any of such properties, just like your acetylcholine. Acetylcholine, it decreases the heart rate, decreases the force of contraction, increases the GI motility. So all these are the properties or the effects of the acetylcholine. But in this case, if you can see this particular pair, physostigmine does not have all these properties. It does not interact with the cholinergic receptor to produce the same action. Whereas in the earlier case we have seen aspirin, paracetamol, both of them have analgesic property, right? But that is not the case over here. Here in that pair, one of the drug is inactive. So here physostigmine actually it does not have that particular therapeutic property. How does it potentiate the action? It just inhibits the breakdown of acetylcholine. So what will happen? The metabolism of acetylcholine is inhibited. The enzyme required for metabolism of ACH is inhibited by physostigmine. Cholinesterase is inhibited. So as a result of which hydrolysis of ACH will not take place. So ACH concentration will remain high in the cleft and it will show the action. Enhanced action will be produced. Similarly, with this particular pair, levodopa is the one which actually produces the therapeutic property in the Parkinson's disease. Levodopa gets converted into dopamine. We have seen that dopamine is given in the precursor form because dopamine actually cannot cross the blood-brain barrier. So it is given in the precursor form, levodopa, which can cross the blood-brain barrier. It will reach CNS and there it will get activated. Okay, but the problem with this drug is that it can cross the blood-brain barrier, but in the periphery itself, okay, that is before it enters your CNS, in the periphery, in the systemic circulation itself, it will be activated to dopamine. Okay, so what will happen? Less of levodopa will reach the brain. Okay, so to avoid that, this particular drug is given in combination, that is carbidopa. Carbidopa, how it enhances the action of levodopa? Carbidopa, it does not interact with any dopaminergic receptor, or it does not get converted to dopamine to act on the dopaminergic receptor. But still the combination has greater action as compared to when you give levodopa. Okay, how it is enhancing the action? By inhibition of the peripheral metabolism of levodopa. So carbidopa enhances the action of levodopa by inhibiting its peripheral metabolism. So then more of it will reach the CNS and it will get converted to dopamine. Activation into dopamine will take place, and that's how its activity will get enhanced. Okay, so these are the examples of supraadditive synergism. Then coming to the next particular combined effect, that is antagonism. Okay, so here one drug decreases or abolishes the action of another. So in this particular situation, both these drugs, okay, this particular type of effect, it is said to be antagonism. Okay, or they are said to be antagonistic to each other. Okay, so here what we can say, that effect of drug A plus B, that is a combination of drug A plus drug B, it is less than effect of drug A plus effect of drug B. So when you consider the individual effects of the two drugs, in comparison to that, the effect of the combination is less. Okay, so that means one drug is decreasing the effect of the other. That's why it is showing the less effect. Okay, so here usually in this antagonistic pair, one of the drug is inactive as such, but it decreases the effect of the other. Okay, so one drug will decrease the effect of the other. That particular drug which is decreasing the effect of the other one, it does not have any property, does not have any therapeutic property as such. Okay, now there are several mechanisms by which antagonism can take place. There are 4 mechanisms by which the antagonism can take place. The first one is the physical antagonism, next is the chemical antagonism, then the physiological or functional antagonism, and receptor antagonism. So these are the 4 types of antagonism which can take place. Now coming to the first one, that is physical antagonism. So as the name implies, this type of antagonism is based upon the physical property of the drug. Okay, so physical property of one drug will decrease the effect of another drug. Okay, now here in this particular example, it will make it more clear. Charcoal, if you consider, okay, charcoal actually it has adsorption property, right? Adsorptive property. So it has the surface phenomenon, that is, it can adsorb certain drugs on its surface, right? So charcoal, it can adsorb alkaloids. Okay, so by adsorption of alkaloids on the charcoal, what will happen? Free form of alkaloids, soluble form of alkaloids will not be available. Okay, so it will prevent the absorption of alkaloids. Absorption of the alkaloids is prevented because charcoal, because of the surface phenomenon, it starts adsorbing the alkaloids. So alkaloids will be adsorbed on the surface of the charcoal and its absorption will be inhibited. So this particular physical property of charcoal, it is utilized to prevent the further absorption of alkaloids in case of alkaloid poisoning, wherein decontamination can be done. Further exposure to the poisoning causing drug can be inhibited because of the physical property of the drug. Now here charcoal does not have any kind of therapeutic property, right? Only this is the one which is having. But because of its surface property, charcoal is preventing the absorption of this particular drug. So here one drug is affecting another drug because of its physical property. Then next type of antagonism is chemical antagonism. So as the name implies, here the two drugs will react chemically. So they will react chemically and maybe they will get converted into some other substance which is inactive. So the product which is formed which is inactive does not show any therapeutic property. Say for example tannin plus alkaloid, when these two are given together, they form insoluble alkaloid tannate. So since it is insoluble, it will not get absorbed. So either of the drugs will not get absorbed. Next, chelating agents such as BAL or calcium disodium edetate. So these are the chelating agents, that is, they will complex certain metals, okay, which are toxic in nature, arsenic or lead. Okay, so these are used in the chelating, or in case of poisoning of these metals or toxicity of these metals if it takes place. So it can be used as a chelating agent. So it will chelate and it will prevent the further absorption of these metals. Okay, then even when you mix two drugs in the same syringe or in the infusion bottle, mostly this is generally practiced that rather than, if you want to inject two drugs, so rather than injecting the two drugs separately, what is done is the two drugs are taken in the same syringe. They are mixed in the same syringe and they are injected in the patients. Okay, so mostly it is done when two injections are supposed to be given, or sometimes if the IV line or infusion is being infused, infusion solution, if it is being infused in a particular person through infusion bottles, sometimes another drug, if it is supposed to be administered, it is mixed in that infusion bottle. But sometimes the two drugs, when they are mixed in the same syringe, okay, they may react chemically. Say for example, thiopentone sodium and succinyl choline. If you mix these two together in the same syringe, both of them will react chemically and they will get converted into inactive substances. So neither of these will show their action. Okay. Then heparin plus penicillin. If heparin is combined with penicillin or tetracyclines or streptomycin in the same syringe, it can react chemically. Or penicillin G sodium and succinyl choline chloride, if they are mixed in the same syringe, then they will react chemically. So they will form inactive products and neither of them will produce their therapeutic effect. So here the antagonism is because of the chemical reaction with each other. The next type of antagonism is the physiological or functional antagonism. So here, as the name implies, the function is responsible actually, or the physiology or the biological effects which are produced by the drug or which are altered by the drug, these are altered in such a way that they antagonize each other's effect. Okay, now say for example, the two drugs which are administered together, they may act on different receptors or by different mechanisms, but the ultimate effect which they produce, okay, they are produced in the opposite directions. Okay, on the same physiological function or the physiological process, the two drugs will have opposite effect. Okay, that is, their pharmacological effect is in the opposite direction. Say for example, histamine and adrenaline on bronchial muscles and BP. Okay, so one of the drug increases the blood pressure, another one decreases the blood pressure. Okay, adrenaline, it increases the BP. Histamine, it can lower the BP. Okay, so histamine, it can produce the bronchoconstriction. Adrenaline, it can produce bronchodilation. Okay, so here two drugs are acting on the same physiological function in the body, but they are acting on those parameters or on those physiological aspects in such a way that two drugs will produce opposite effects on the same effector. So what will happen, since both of them are acting in the opposite direction, they will nullify. One drug is increasing the BP, one drug is decreasing the BP. So if such drugs, if you give together, what will happen to your BP? It will remain unaltered, right, depending upon how much of the effect is being altered by one particular drug or another drug. Okay, same way glucagon and insulin, they have opposite effect on the blood glucose level. Insulin can reduce the blood glucose level, glucagon can enhance the blood glucose level. Okay, so both are having opposite effects on the same particular aspect in the body. Okay, so such type of antagonism is known as physiological antagonism or functional antagonism. So here physiological alterations are done in such a way that opposite effects are being produced on the same effector. Then the last type of antagonism is the receptor antagonism. This is quite common, which is shown by most of the drugs. Okay, so here one drug can block the receptor action of another drug. Okay, so here one drug is acting as an antagonist on the receptors which are stimulated by another drug, which is acting as a agonist. We have seen both these terms, right? Antagonist is something which can bind to the receptor, but it will not stimulate that receptor, no conformational changes. But agonist is a type of substance which can bind to the receptor and further stimulate it, so that the signal will get transduced. Okay, so this is a very important mechanism of drug action. Okay, that is binding to the receptors. Okay, because mostly the physiological signals, okay, these are being produced, or these are being carried through the interaction with the receptors, is what we have seen. We have seen the different types of receptors. There are different mechanisms by which the drug can produce its action, and action can be converted into effects by certain transducer mechanisms. So it's a very important mechanism by which most of the drugs will act. It will act by interacting with some or the other physiological molecules. So blockage of such type of receptors, it may alter the physiological effects, right, of one particular drug. Okay, the one which is blocking the receptor, obviously it will block the effects of the agonist, right? So likewise, one drug can diminish or totally abolish the action of another drug. Okay, now here the receptor antagonists, these may be quite selective. Okay, there are certain selective antagonists which are available, that is, they can antagonize only a particular type of receptor. Now say for example an anticholinergic, it will oppose the contraction of the intestinal smooth muscle contraction, which is induced by cholinergic agonist. That is, the intestinal smooth muscle contraction which is produced because of the interaction with the cholinergic receptors. So these are only blocked by an anticholinergic drug. These type of drug will not block the effect of histamine or 5-HT. 5-HT can also make the intestinal smooth muscle contract. Histamine can also make the intestinal smooth muscle contract. But these effects will not be blocked by anticholinergic. Anticholinergic drugs will block the contraction of intestinal smooth muscles, only those which are mediated through the cholinergic receptors. Okay, so antagonists are also specific, or these are quite selective in nature. They can block only certain type of receptors, but not the other type of receptors. Now this type of antagonism, that is receptor antagonism, again can be of further subtypes. That is, it can be either competitive antagonism or non-competitive antagonism. Now coming to the first one, that is competitive antagonism. Now again, in this competitive antagonism, it can be of equilibrium type or non-equilibrium type. Okay, now as the name implies, competitive antagonism means here there will be a competition between the two substances for the same site. So here the agonist as well as the competitive antagonist will compete for the same site on your receptor. Okay, so there will be some structural similarities between the same. Now you can see over here agonist and the competitive antagonist, they are structurally similar, plus both of them have the affinity towards the same receptor. So they will compete with each other, and the competitive antagonist, depending upon the concentration of the two, relative concentration of the two, the competitive antagonist may bind to that receptor and block the receptor. Now once the competitive antagonist binds here, agonist will not be able to bind at this particular receptor, right? Okay, and since this competitive antagonist, it just has affinity but it does not have intrinsic activity. Okay, it does not have any ability to stimulate the receptor or produce the conformational changes in that particular receptor. So no response is produced due to the antagonism of agonist. So here agonist is prevented from being bound to the receptor. Instead, a competitive antagonist is getting bound to that particular site. So it blocks the receptor. So no effects are seen as a result of competitive antagonism. Okay, now since this is an equilibrium type, okay, this particular antagonism, it is a reversible type of antagonism. Okay, and it depends upon the relative concentrations of the two, agonist and antagonist, in what concentrations these two are present. Okay, so if you progressively increase the concentration of agonist, this block can be overcome. Okay, it is surmountable. Alright, if you enhance the concentration of your agonist, it will displace your antagonist and it will start producing the action. Okay, and peculiarly this particular antagonism, it takes place in presence of the two. Agonist also has to be present. There is a competition between the two for the same site. Okay, now in this type of antagonism, there is only a parallel shift in the DRC of the agonist. Okay, if you can see over here, this is the DRC of your agonist A. Now this is the DRC of the agonist in presence of the antagonist B, but here the amount of antagonist is say one time. Okay, that is say a particular amount. But here what has happened? Here we have increased the amount of antagonist. You can see over here multiplied by 10. Okay, so here the concentration of your antagonist, it has been increased to 10 times. Okay, higher amount of antagonist is present over here. So what has happened to your DRC? It is still shifted towards the right. Okay, so here in this type of antagonism, what happens is the DRC of a particular drug, the dose response curve of a drug, it is shifted towards the right hand side, and there is parallel shift in the DRC of the agonist. If you can see over here, the maximum response is not suppressed, right? It's the same. Only thing is there is shift in the DRC. That is, higher dose of your particular antagonism may be required to produce the same amount of action. Okay, so here just a parallel shift in the DRC is seen over here. Okay, there is no suppression in the maximum response of your agonist. Okay, so as you increase the amount of antagonist, there will be shift in the DRC of your agonist. So here the extent of shift, it depends upon the affinity and the concentration of your antagonist. More the affinity or more the concentration of your antagonist, more will be the shift towards the right hand side. Okay, now on the contrary, if a partial agonist is given, it has affinity for the same receptor as your agonist, and also it competes with and antagonizes the full agonist. So a partial agonist will also antagonize the full agonist, whereas since it has intrinsic activity in between 0 and 1, it has a partial intrinsic activity, so it will produce sub-maximal response of its own. It will not show the full action, or it will not show complete antagonism. Okay, then next type is the competitive antagonism non-equilibrium type. Now here the competitive antagonism, now here the concept remains the same. That is, there is a competition between the agonist and the antagonist for the same site. But here the antagonist gets bound to your receptor with strong covalent bonds, or it may dissociate from that receptor very, very slowly, so that the agonist is not able to reduce the receptor occupancy of your antagonist molecule. That is, in the earlier case, in the equilibrium type, what we have seen, it depends upon the relative concentration of the agonist and the antagonist. And if you enhance the concentration of your agonist, the competitive antagonism, it can be reversed, right? But that is not the case with this type. In this particular situation, the antagonism is not surmountable. No matter how much you increase the concentration of your agonist, it cannot be reversed. So it is an irreversible or non-equilibrium antagonism. Okay, and here the agonist DRC, it is shifted to right. Okay, no doubt this is the DRC of your agonist, and this is the DRC of agonist in presence of certain amount of your antagonist C. As you go on increasing the amount of your antagonist, the DRC, of course, it will be shifted towards the right, but at the same time, what is happening to your maximum level over here? That is also getting lowered. Okay, as you increase the amount of antagonist, the maxima is also getting suppressed. So DRC will go on flattening. That is not the case with the equilibrium type. Here, there only the shift in the DRC, parallel shift is taking place. Over there, it was surmountable, but this is not surmountable. Okay, no matter how much you increase the amount of agonist, your antagonism will not be reversed. Example is phenoxybenzamine. This is a non-equilibrium antagonist of adrenaline and the alpha-adrenergic receptors. Then, the next type of antagonism is non-competitive antagonism. So, as the name implies, there is no competition between the two. Okay, agonist binding site and non-competitive antagonist binding site, these are different. It binds to an allosteric site. It does not get bound to the substrate binding site. This is the actual site on the receptor on which your agonist is binding and producing the action. But here in this case, the non-competitive antagonist, it does not bind to the binding site of your agonist, but it binds to allosteric site, some other site on the receptor. Okay, so as a result of that, there won't be any competition between the two, right? They are not binding to the same site. So that's why it is called as a non-competitive antagonism. Okay, so now though there is no competition for the same site, still once the non-competitive antagonist it binds to the receptor, it will alter the receptor in such a way that your agonist will not be able to bind over here. So it will produce some conformational changes. As you can see, what has happened over here? If you can see this structure of your receptor, will this fit over here? No, because this non-competitive antagonist, it has produced some conformational changes over here, so that agonist will not be able to bind its place. It is free, but still agonist will not be able to bind over here. Okay, or maybe the signal will not be transduced further to convert it into the response. Okay, now over here, since the agonist and antagonist, these are combining to the different sites, there is no competition in between them over here. And even if you increase the concentration of your agonist, it will not help, right? Because there is conformational changes. So this type of antagonism also cannot be reversed by increasing the amount of your agonist. So as you go on increasing the concentration of your antagonist, again the shift of your DRC will take place towards the right hand side. This is the DRC of your agonist, and the DRC of agonist in presence of your antagonist, non-competitive antagonist. So here also, just like your non-equilibrium type of competitive antagonism, here there is a shift in DRC towards the right hand side, plus there is flattening. As you go on increasing the amount of your antagonist, the DRC will go on flattening. There is a reduction in the maximum level of action. Okay, now these are some of the points which differentiate between the competitive and the non-competitive antagonism. Okay, specifically the equilibrium type. The non-equilibrium type of competitive antagonism is, you can say it is a similar type as compared to the non-competitive. So basically the difference between the equilibrium type of competitive antagonism and non-competitive antagonism. There are some points which are discussed over here. So as we have seen that antagonist binds with the same receptor as the agonist. So here there is the same site on the receptor to which they bind. But here the non-competitive antagonist, it binds to another site on the receptor. Next point of difference, the antagonist, it resembles chemically with the agonist. Their structure may be similar so that it can fit in that particular area. But here in case of non-competitive, it does not resemble because its site is totally different. Then parallel right way shift of agonist DRC is seen over here. Right side the DRC gets shift, and it is a parallel shift which takes place. But here in case of non-competitive antagonism, flattening of the agonist DRC is taking place. Rightward shift is there, but flattening also, maximum response is lowered. Okay. Then the same, next point of difference is the same maximal response can be attained by increasing the dose of agonist. That is, the antagonism is surmountable. If you increase the agonist concentration, the antagonism can be reversed. But in this case, the maximal response is suppressed. Okay, so it is unsurmountable. You cannot gain back the activity of your agonist even if you increase the concentration. The next point is that the intensity of response, it depends upon the concentration of both the agonist and the antagonist. But here the maximal response in case of non-competitive antagonism, the maximal response, it depends only on the concentration of the antagonist. Okay, then examples are listed over here. In case of competitive antagonism, it is ACH and atropine. Atropine is a competitive antagonist of ACH. Naloxone is a competitive antagonist of morphine at opioid receptor. In case of non-competitive antagonism, bicuculline is a non-competitive antagonist of diazepam. So binding site is different on the same receptor. So these are some of the important questions which can appear from the pharmacodynamics, which we have seen in 5 parts. Note may be asked on the mechanism of drug action, then the transducer mechanisms or the types of receptors as we have seen. So that's very important from exam point of view. Then the theories of receptors are quite important. The 2 theories which we have seen, receptor occupation theory and the 2-state model. Okay. Then the combined effects of the drugs, which we have seen in today's lecture, synergism, antagonism, or simply a note on antagonism or synergism may be asked. One more important concept is the dose response relationship, how the response can be altered based on the dose, and what are the different concepts which we have seen, selectivity, then the risk benefit ratio, the therapeutic index, and so on. Okay, so all those small concepts are also quite important, which we have covered in the pharmacodynamics. Of course, the principles of actions are also important. This is the reference. Thank you.